Good morning. My name is Alexandra Lansky. It's my pleasure to be here this morning with Dr. Gregg Stone. We're going to be talking about the INFUSE-AMI trial. So, Greg, can you give us a little bit of background on the trial?
Sure. Thanks, Alexandra. So, as you know, primary angioplasty in patients with ST segment elevation MI is now really the preferred way almost around the world to treat such patients. And while we've gotten very good at opening up the infarct artery and doing it pretty expeditiously and restoring normal TIMI3 flow in the infarct vessel, what often happens is that we still end up with large heart attacks, and we don't salvage as much myocardium as we could. And this results in patients who develop heart failure and late cardiac death. So there have been many approaches that people have been trying to improve myocardial recovery after primary angioplasty and STEMI. And two approaches that have been particularly intriguing to people focus on the same thing, and that is trying to reduce distal embolization of thrombus during the infarct procedure. And that's because we know that the infarct lesion itself is rich with this very soft, friable necrotic core. It develops thrombus on top of it, and when we use our balloons and stents to open the vessel, we invariably embolize that downstream, and it can clog in the capillary system, cause microcirculatory block, and thus, even if we get good flow in the superficial epicardial vessel, we're not getting any blood and nutrients into the heart muscle itself. So two approaches that people have taken are simple thrombus aspiration, that is using a tube-like catheter just to extract the thrombus before it embolizes downstream, or the intracoronary infusion of the potent antiplatelet agent abciximab. And of course, abciximab has been used a long time, given intravenously, but if you give it intracoronary, you can obtain up to 1,000 times greater concentration of the drug, and it can literally disaggregate the platelet clumps in the thrombus and therefore prevent macroscopic emboli, at least from going downstream. But conflicting prior studies have been conflicting with both of these approaches, in part because the patients have been different, the methods have been different, and people have studied patients actually that are having very small heart attacks, such as non-anterior infarcts, or patients who present too late. If you present after 6 hours after you're having a heart attack, you pretty much have a transmural heart attack. So you really have to present early as a patient if you're going to have any chance of being able to reduce the infarct size.
So how did you design your trial then?
So what we did was we designed a unique trial with just a specific, very selected patient population designed to see if infarct size could be reduced after primary angioplasty with these two techniques. So we took patients with only anterior myocardial infarctions due to occlusion of the proximal and mid-left anterior descending artery in patients presenting early, within the first few hours of a heart attack, before the time window for effective myocardial salvage is closed. And at 37 sites in 6 countries, we randomized 452 such patients to one of two different therapies. The first therapy was intracoronary abciximab, but rather than giving it through the guide catheter, as all other prior studies have done, in which case a lot of the drug can actually go down the circumflex or blow back into the aorta, we gave it through a special weeping balloon catheter, a catheter that actually allows the drug to seep through the pores of the balloon and therefore infuse the drug right at the site of the blockage into the thrombus and at the infarct site lesion. That's a catheter called the Clearway RX catheter. And the second approach we took was thrombus aspiration, and we used the 6 French export catheter, the exact same device that in the TAPIS trial had resulted in very, very good clinical results, but no difference in infarct size and only modest other improvements, making the results questionable but promising. And so we did a 2x2 factorial randomized trial where one of the 4 groups got both approaches, one group got one, the other group got the other, and then one group got control, which is just balloon and then stent.
So what were the key take-home messages from the study?
So the key findings were that the intracoronary abciximab group, with the drug delivered through the Clearway RX catheter, was able to reduce infarct size. And we saw a reduction from about 17.9% of the left ventricle being infarcted territory as measured by cardiac MRI at 30 days, and that was reduced to about 15.1%. So about a 2.8% salvage of myocardium, if you will. And that's significant. P-value is 0.03. It's a modest amount of myocardial salvage, to put it in perspective. We were hoping for 6% or greater, but we did see this significant reduction. And there were trends also for less regional wall motion score, better ejection fraction, etc. In the aspiration arm, surprisingly almost, we saw absolutely no difference. The infarct size was about 17% of the left ventricle, regardless of whether or not aspiration was used.
Mm-hmm.
So I think there were other less important results of the study, but those are the take-home messages.
And how about the bleeding complications with the bolus of ReoPro?
Sure. So the trial wasn't powered to, for either efficacy or safety complications, so we would have had to have big differences present to detect them. And there were no clinically significant differences in either MACE events, death, heart failure, reinfarction, TVR, TLR, stent thrombosis, nor were there differences in safety.
Right.
So we were hoping that a bolus only, and I should also mention, we did the whole trial on a background of bivalirudin anticoagulation.
Mm-hmm.
So no patient got a 12-hour infusion of abciximab, and again, half the patients, those randomized to abciximab, got the bolus only. Now, bolus-only abciximab can stick around for up to 12 hours, so it's not like it's a very, very short therapy. But while we saw weak trends to maybe a few extra bleeding events, there was no statistically significant differences, nor in thrombocytopenia.
So I guess one of the questions would be, with that kind of difference on the MRI, what do you think that would translate into in terms of clinical events?
Right.
How meaningful do you think
and that's really the question. And would it translate into improved clinical events just in the population we studied? And what if you liberalized it to, again, patients with smaller heart attacks or one who came in later? And there have been strong studies relating infarct size by cardiac MRI to survival, but it's not such a one-to-one relationship that we can predict. We would hope that it would lead to modest, reductions in composite endpoints such as death, new onset heart failure, readmission for heart failure, possibly reinfarction. But we would really need to do a clinical outcomes trial, since every therapy has cost associated with it and potential side effects such as bleeding.
So what do you think you're going to see clinically? I think there's been a relatively large adoption of aspiration on the basis of TAPIS, and your trial is showing that may not be beneficial. What do you think you're going to see in terms of treatment for MI?
Well, the use of aspiration is really all over the place. In Europe, there are many centers who aspirate every single acute MI. Other centers are selective. The United States has been slower to adopt it as a therapy. So I think that there will be people who will look at this and say, look, there's absolutely no reduction in infarct size. What could the mechanism possibly be if it doesn't reduce infarct size? And this was a very carefully controlled study. And so I think many people will stop using it routinely, but will still selectively use it, as would I. If you've got an artery that's just full of globular thrombus that you can see, that's not going to be a happy result when you stent it. Now, on the other hand, I should say that there are two very large-scale trials ongoing with aspiration versus control, called the TOTAL trials and the TASTE trials in Sweden and in Canada, that are going to enroll somewhere between 4,000 to 7,000 patients apiece. In a very simple randomized trial with mortality as a primary endpoint.
So those will be definitive.
Those will
really
be definitive.
Address the issue.
And clinical outcomes always trump any surrogate endpoints, although I would predict from this trial that those are probably not going to be favorable.
Right. So any final recommendations to our interventionalists out there?
Yeah, well, thanks. I think INFUSE-AMI has been an amazing process because we screened 3,600 and I think 18 patients to be able to find these 452. And it was a unique way to say these are the patients with the greatest clinical need and whom you could reduce infarct size in. And I think that will serve as kind of a model for future studies wanting to investigate new therapies to reduce infarct size. From a clinical point of view, I think the intracoronary abciximab clearly is promising. We gave it a unique way that is, again, right directly into the clot itself. And so I think that does certainly deserve further study. And I know of several small studies that are ongoing in that. And again, I think a large outcomes trial would be warranted. Yeah. And for aspiration, I think right now I would say I don't see a reason to aspirate routinely. Right. Do it selectively when you think there's very large thrombus that your experience has said you're not going to get a good result unless you remove visible, amounts of clot. But then let's wait for the large outcomes trials to really deliver the final word on aspiration.
Okay, well, I want to thank you, Greg. This was very good, and congratulations on a really phenomenal trial. Thank you.
Thank you.
Thank you.